we titled this, but that's normal, right? So I'm trying to take this opportunity to kind of redefine that normalcy, and really dive deep and understand our bodies beyond our expectations. Today, specifically, we'll be talking about myths surrounding fertility and chronic pain. Just a quick disclaimer, I have no financial disclosures or affiliations to report. Everything in this presentation is for educational purposes only and not intended to replace any personalized medical advice. So, a little bit about me. I am the lead physician assistant at Westchester Medical Center. I've been there for a little bit over 5 years now. I'm also an instructor in obstetrics and gynecology at New York Medical College. So I teach medical students, PA students. I also teach residents. I'm really passionate about mentoring future providers as much as I am passionate about teaching my patients and promoting patient education. My job encompasses all of the inpatient hospital aspects. So, emergency department visits, if you were to come, I'd be the person who would consult and see you in the emergency department. I also do inpatient consultations, which means if you're admitted and you have a gynecological problem, I'm part of the team that would evaluate you. I also cover gynecologic admissions. So any patient that's hospitalized, I would be taking care of them. And then I also participate in surgery, so surgical management. I get and have the privilege of treating women in all stages of their lives. So everywhere from teenagers having issues with their periods, maybe seeking birth control advice, all the way to postmenopausal women who might have some issues in their menopausal phase of life. And I treat a variety of gynecological conditions. So anything with early pregnancy problems, pelvic pain, abnormal bleeding, pelvic organ prolapse, and I even and am most passionate, I think, about treating gynecological cancers. So certainly all of those things have played into patient education and my passion. So to start off, I would like to go over a little bit of understanding our anatomy. I thought these pictures were cute, but we'll dive into some other photos and pictures. I don't know if Glenn, at least if you wanted to give a little heads up.
Yeah, so I'm gonna say trigger warning only because we're gonna see like real pictures. Like these diagrams are cute and floral and beautiful. I'm really excited because we actually get to see what it looks like. You may not be as excited as I am about that. So she's like letting you know that we're gonna see some real photos of real organs in someone's body.
Here's the first label. So here is our vaginal canal. You can see it's rugated. You can see this is the mucosa. I have the next slide goes into a little bit more about their function, but I'll just kind of run through a basic anatomy overview with you guys. So here's vagina leading up to the cervix, which is the entryway into the uterus. And then we have our endometrial cavity, which is this nice little cavity inside of the uterus, which houses pregnancies, can also cause issues like endometriosis if any of these cells escape onto the outside of the uterus. We also have our myometrium, which is this muscle wall right here. And this is typically notable maybe with like fibroid growth, and is, part of the reason why you have cramps during your menstrual cycles. That's that big muscle that contracts. We also have our ovary right here, which carries all of your egg supply, which actually you're born with. So you already are born with all of the eggs that you'll have, just like this diagram, unlike other diagrams that show you that the uterus and the fallopian tube and the ovary are connected. They're not. So your fallopian tube, this guy right here, actually has at the end something that's called fimbriae, which are these like finger-like projections that literally just like float like in the abdominal cavity. And whenever you ovulate and you have that egg released from your ovary, these little guys, their function is to actually pick it up and suck it into the tube. And then the tube itself will move it down all the way into the endometrial cavity. So yes.
This blew my mind.
So yeah, to that point, they're not connected, which I wish I could show you guys like how it actually looks like in the body, because I think it's such a great way to understand. So yeah, so here are your follicles. We'll touch a little bit about that today with like certain conditions that may cause ovarian cysts. And then, yeah.
Yeah, I was fascinated by this.
My next slide is showing like this, what we call a sagittal view. So it means if you were to cut your body in half and then take a look at it, that's what we're looking at right here. So this right here is your uterus. This is the muscular home of where pregnancies grow, where your period happens every month. It is made up of the endometrial lining, which is this highlighted area right there, as well as your myometrium, which is this muscle layer in here. And then you have your serosa, which is the outer lining. I think it's important to understand these things because there are conditions that cause chronic pelvic pain that do involve all of these. And I think when I've sat down with my patients and actually explained like the cells inside of your uterus implant in other places for endometriosis, and that's what causes your monthly bloating, cramping, and pain, I think it gives them a better idea of what's going on. And I'll dig into that a little bit later. Your ovaries, you know, we have like an okay view right here. They're the two small glands that store eggs and produce hormones every month. So estrogen and progesterone are those hormones, and those influence your ovulatory cycles, which we'll also dig into some. Next, I have a description of your fallopian tubes, which again is that passageway that carries the eggs from the ovaries to the uterus where fertilization happens. And then down here we have our cervix, which is the lower part of the uterus that is like the entryway into the uterus and connects to the vagina. During pregnancy, this cervix will dilate during labor. And this is also the area that's checked routinely during your pap smears. The vagina here is this muscular canal that connects to the cervix to the outside of the body and is a part of menstruation, sex, and childbirth. There's an important takeaway that I would like to show with this picture here, that there are more than just your reproductive organs in the pelvis. So I think that's important to note when we talk about chronic pelvic pain. Although I'll be touching primarily on gynecological reasons, I think it's important to note that there's more than just your uterus and your fallopian tubes and ovaries in there. You also have your intestines, so the rectum here, and then the bladder. So certainly if you're having problems with pelvic pain, it could be maybe something related to like irritable bowel syndrome, could be interstitial cystitis, which is an issue with the bladder. So just something to keep in mind. So here, this is just my slide. I'm going to show a real picture now. I tried to incorporate these after Clint and Lisa and I ran through this, just so that I can give you guys a trigger warning if you don't want to see real pictures, but this is real pictures from laparoscopic procedures to show you guys what normal anatomy looks like, or real anatomy looks like.
I can't wait. Look at that.
This is a picture of a, you know, what a normal uterus looks like. So this was a picture that was taken laparoscopically. So what that means is that we made a small incision in the belly and dropped a camera in there. And then we took a picture. Also of note, this uterus is like kind of, it's standing, but we do have a instrument inside of the uterus that's holding it up that helps us during procedures. So I just wanted to, let you guys know, because in its natural, I don't know, like natural habitat, lack of better word,
Yeah.
it actually is like laying on top of your bowel. So it's just kind of chilling there, everything. So you can't really see the bladder, but it's underneath this layer of like peritoneum, which is what covers the inside of your abdominal wall cavity. And then here is the rectum. So this is your intestine. So as you can see, all the anatomy is really close together. So as you can imagine, anything like fibroids, if you have a big fibroid, or even, pregnancy, anything that enlarges the uterus would certainly affect, like maybe give you constipation or give you problems with like urinary incontinence. So just kind of giving you guys a better idea of like how everything is connected and how it might impact your health. So this is false. Period pain is not a part of being a woman. So pain is actually a signal and not a part of the natural process. And I'll dig into what that means and, a little bit more. So periods, they can be uncomfortable. I'm not saying that they're not. There's certainly discomfort associated with our menstrual cycles, but it shouldn't be debilitating. If you're having severe pain during your menstrual cycles, that could be a sign that there's something that is underlying that's not right. This is a common misconception that I think really does contribute to delayed diagnoses in women. So, I feel like we are taught that period pain is normal. It's very normalized. And in some ways, I guess it depends on what you describe as pain. Discomfort is normal. And I'll explain a little bit more about that, but it shouldn't be something that's, causing you to miss school, causing you to miss social functions, things like that. Oh, and if left untreated, it can certainly cause any problems with like trying to get pregnant in the future. So, what is a normal menstrual cycle? So a normal menstrual cycle is more than just your period. It's a complex rhythm that involves hormones, ovulation, and really your entire reproductive system. While there's variation from person to person, this is what it normally looks like. So cycle length can range from 21 to 35 days. This starts from the first day of your period. So that's what we consider day one. On average, most women have a cycle of 28 days. Your menstruation, the duration is typically 2 to 7 days. It can it doesn't have to be the same every month, but it can be shorter some months, longer other months. But it shouldn't be something that you're bleeding for more than 7 days. If you're bleeding for more than 7 days, that's not normal. Your flow shouldn't soak through a pad or a tampon every hour. I think that it's okay for your cycle to be light at the beginning, maybe get heavier. Some women do have heavier menstrual cycles, but it's important to note that really heavy bleeding that's causing you to be anemic, maybe you're lightheaded, dizzy, short of breath, that's not normal. The color does vary. Variation is normal. And that's something that I did want to touch on because it's something that I've seen on TikTok. I don't know if you guys have seen these things on TikTok. They talk about like menstrual blood color and stuff. And that's not anything for you guys to be concerned about. Bright red, dark red, brown, all of those are normal for menstrual blood. It is normal to have small clots, like smaller than like a quarter size. But if you're having, large clots, then that's out of the norm. Total blood loss is about 30 to 80 milliliters over the course of your period, which would be somewhere around like 2 to 6 tablespoons. If you're bleeding more than that, the way we quantify it, so things I ask patients when they come to the ED if they're having heavy bleeding is usually quantified by like how many pads they're using. So if you're using like 10 pads a day throughout the entire time of your menstrual cycle, that to me would be kind of concerning, you know? So I guess that's kind of the way that we quantify it. But any of these other things could also key you into that, you know, soaking pads, or a tampon every hour, or even having like cloths that are bigger than a quarter size. So just going through a couple of the phases of our menstrual cycles. So the menstrual phase is day 1 to approximately day 5. The uterus is shedding its lining during this time. Your hormones have dropped, and this may cause you to feel tired, moody, or even have like cramps, and that's due to the prostaglandins, which is a fancy way to like call a chemical that's released during your period that causes your uterus to cramp. So during this time, like we had mentioned, you know, it's not necessarily that it should be pain. You can have discomfort during your period because your uterus is cramping. Then next we have our follicular phase, which can overlap with it overlaps with your period. So we say this is like usually day 1 to 13. Your brain is signaling to your ovaries that it's time to mature an egg. So during this time, your estrogen is going to rise and be at its highest, which is, I'm sure lots of you guys have seen like, oh, I'm like in my follicular phase. So I'm like living my best life. My energy's up. I feel great. I can do all these things. And that's why estrogen is high. So you're going to be feeling pretty good. During that time, what your estrogen is doing as well, it's actually thickening that lining of the uterus. So I don't have a picture of a uterus other than this little icon. So this little cavity here, when you shed it, it becomes thin. And then the estrogen, as it rises, starts to make it grow in preparation for ovulation. So that, you know, the egg can have like a little nice bed to implant in. So ovulation day is approximately day 14. I would say it ranges anywhere between like probably day 10, 11 to even like day 15. It just kind of, again, every patient is different. Every female has a different cycle range. I thought this icon was really cute because it actually shows like the ovary like expulsing the follicle. During your ovulation, your estrogen rises to the highest point that it will, and that signals your body to trigger what we call an LH surge, which I should have written it out. It's a luteinizing hormone, which is another hormone that actually causes you to ovulate. So that hormone tells your body and the ovary, hey, it's time for you to expulse that baby out. Not baby, that was the wrong term, but you know. Not a baby.
Actual baby.
Not a baby.
The potential baby.
Correct. So, yeah, this is, you know, your fertile window. So you'll hear a lot of people when they talk about fertility, like, you know, tracking their fertility, their cycles. This is the time where, you know, your provider is going to tell you to have sex. But it is not limited to this time. I'd like to say that now and early. You can still get pregnant outside of this ovulation period. So yeah, but yeah, that fertile window is usually like 5 to 6 days in total. Next is your luteal phase, and that is day 15 through 28. Again, we're basing this off of a 28-day cycle. Progesterone starts to rise to support a potential pregnancy. And if there's no pregnancy, your body will recognize that and your hormones will drop. And then your body knows that it's time to shed that endometrial lining. So They recognize there was no implantation of a mature follicle. Okay, there was no fertilization. We'll go ahead and start, you'll start menstruating shortly after this. During this time, you might experience what we call PMS, so bloating, mood swings, breast tenderness, and it's all related to this like quick hormonal shift. Here's another quick diagram of what a menstrual cycle looks like. So, so here we have, this is a nice little view of the endometrial layer, like I was mentioning. Here's the ovarian cycle. So you can see day 1, you're shedding that lining, you're menstruating. During that time, you're growing a follicle and it's maturing. And then you have your proliferative phase, which is when that follicle is maturing here. You can see estrogen is rising, and then that LH, that luteinizing hormone, triggers your ovulation, and then it drops again here. Progesterone starts to rise because it's preparing for a possible pregnancy. And you can see the endometrium there is like nice and thick, nice and juicy, ready for ready for that implantation of the mature follicle and fertilized egg. And then once it recognizes there's no implantation, it'll drop right there and start your menses again.
That's a drastic drop. It's not like gradual. It's like boop, like all the way down.
Which is why you feel like shit.
Yeah, like this makes sense. Like it's it gradually going up all nice and easy, and then like that drop is like a roller coaster ride. It's like whoop.
Yeah,
I get it now.
So things that are normal for your menstrual cycle, just a little recap here. Regular timing. So again, not exactly 28 days, but you should be having a period every month. Manageable cramps. So again, periods are uncomfortable, right? You're going to have bloating, you're going to have cramping, you have bleeding, your hormones are shifting, you're going to be uncomfortable, but it should not be debilitating pain. Flow that isn't too light or too heavy. You shouldn't have like really large clots, flooding, which means like you're bleeding so much that you're soaking through your pad. Now you're like also soaking through your underwear, you're staining your clothes. That's not normal. Ovulation signs like clear cervical mucus are also normal. And that could be a whole chat in itself about, abnormal vaginal discharge versus normal. But just throwing a little shout out there, normal mucus-like discharge is expected. And then mild cramping, like I had mentioned, which the fancy term for that is Mittelschmerz, which you guys don't need to know, but I don't know why I like that word.
It's an interesting word. I'm gonna go around saying Mittelschmerz from now on, just as like a code word, because I'm like, the Mittelschmerz got me today. So like, and then everyone's gonna be like, what do you mean? I like this.
So, I'm just Mittelschmerzing today.
Yeah, like that's just what it is. It's just what it is. I'm taking that medical term and I'm incorporating into everyday life. We're gonna make it fetch, guys. We're gonna make it fetch.
I love this. So another quiz time, and I forgot to put the quiz time slide in front of this one.
No, we're fine. We're good.
Here's a statement that we'd like to share with you guys. Women are moody because of hormones. Is this true or false?
I'm gonna say I don't know. I feel like it's true. I saw that dip. I feel like that roller coaster makes me go on a roller coaster. So I'm gonna say it's true. I got a false, I got a true. Oh, did you want to know true? Okay, I think we're mostly true and a false. Oh, you're muted. You're muted.
So while your hormones do influence your mood, they're not the sole cause of mood swings. I feel like this really does oversimplify complex emotional and physiological factors that really do unfairly pathologize women's emotions. So
Yeah,
let's dive into that a little bit deeper.
like capitalism. I want to read what Erica said here. She's like, but like men are moody too because of their hormones. Yes. And Ada's like, yes, like capitalism. That will make me moody too. I agree.
And so that is the whole point. So in a way, it's not untrue, right? Hormones certainly impact your emotions. They impact how you feel. I'm not saying that they don't, but I think that there is an unfair assumption that because we have you know, these like hormonal changes that we're moody and emotional. So why is this misleading? Hormones, they do affect mood, but they don't control it alone. So estrogen, progesterone, those influence our brain chemicals like serotonin, dopamine, GABA, and those are actually the things that affect our mood. So maybe we should blame our serotonin levels, which I 100% do. And like, I take an SSRI and I am not ashamed of that. It helps my serotonin stay stable.
Exactly. Exactly. Let's call it what it is. Let's call it what it is.
Mood changes, and like you guys saw, like they're normally during those transitions. So like anytime that you have a hormonal shift, this can be during PMS, like we talked about with menstrual cycles, postpartum. Your hormones change drastically when you're pregnant and then when you're no longer pregnant. So that can certainly affect us. But not every woman experiences. Of course, just a little shout out to like mental health, since we're also going to be covering that this week. External factors do affect our emotions. So, stress, trauma, sleep deprivation, mental health conditions, as I had previously mentioned, anxiety, depression, nutritional deficiencies like iron, B12, omega 3s, and then chronic pain can absolutely affect the way you feel on a daily basis. As we mentioned, there is a gender bias, right? And you guys even, I'm so glad you guys are the ones that brought it up.
Right? Yes.
So this myth is often used to dismiss and stereotype women's emotions as hormonal or irrational. And really, these could just be responses to real life shit that you're dealing with.
Yep.
Or, you know, it could be due to another cause that should be evaluated, or you should, you know, feel comfortable seeking a mental health professional for. So all of this to say is, you know, it's a 50-50 game here, and we're not playing gender biases.
Right. Not here. Not in this house.
Here we have another one. So this statement is, you're too young to have serious chronic pelvic pain issues.
We got a very false. False. Exclamation point, exclamation point. So I think the consensus seems to be false.
So yes, you guys are right. It is false. Most underlying conditions actually start in teenage years. So we'll dig into that now. So here's some of the underlying conditions I'll be covering today. First off is endometriosis. So like I had mentioned, this is when the cells inside of the uterine lining attach to areas where they're not supposed to be in. So they can attach to your fallopian tubes, your ovaries, the outside of your uterus. And as you guys can remember, there's tons of other anatomical structures there. So it can also affect rectum, bladder, etc. These cause extreme pain. Endometriosis starts at an early age, can start as soon as you start having menstrual cycles. So no, you can certainly have chronic pelvic pain issues at a young age. Fibroids are another one. So these are these non-cancerous benign growths in the uterus that can lead to heavy bleeding and cramping. Adenomyosis, which I'll actually lump in with endometriosis because it's essentially the same thing. The only difference is that adeno is endometrial cells that invade that muscle wall of the uterus. So a little bit different in sense of like diagnostics, like the way that we diagnose them, which I'll dive into in a bit. And then we have pelvic inflammatory disease, which is this chronic infection that starts to cause scarring in the pelvis, and it can cause tons of inflammation, pain, and other associated symptoms could be fevers or unusual vaginal discharge. PCOS is another underlying condition which could certainly cause issues with chronic pelvic pain. It's a little bit on the lesser spectrum, but we'll still cover it today. But PCOS is a hormonal imbalance that doesn't allow you to have regular ovulatory cycles, so you don't have periods, and therefore it can add this additional cramping and bleeding during periods. So on the topic of painful periods, I'm just going to go over some like fancy medical terms here, but primary dysmenorrhea, which dysmenorrhea is a word that we use for painful periods. This type is the, discomfort that's normally caused by menstruation. The uterus contracts by those chemicals I mentioned, prostaglandins, and those are the things that help your uterus clamp down and shed your endometrial lining. Those high levels of prostaglandins can cause really intense uterine contractions that lead to pain, cramping, and discomfort. And certainly can affect conditions where those endometrial cells have escaped their home, inside of the uterus. Secondary dysmenorrhea is secondary causes of pelvic pain. So this is actually the painful aspect of it. So, this pain is due to things like all those conditions I just mentioned: endo, fibroids, adeno, pelvic inflammatory disease. They usually get worse over time and won't go away without management. This can include severe ranges of pain like lower back pain, nausea, headaches, sometimes even vomiting. Can also interfere with your day-to-day activities like staying home from work and missing social events. So just to start off with one of the conditions, we'll start off with PCOS. Polycystic ovarian syndrome is a common hormonal disorder that affects the way that your ovaries work. So despite the name, because I almost thought about making this one of our myths, but you do not need to have ovarian cyst to have PCOS. Misleading in the name. Unfortunately, this is just the name that the medical community has given this condition, but is not limited to that. So really, true PCOS is this hormonal imbalance where you have too many androgens, which are the traditionally thought of as male hormones, so like testosterone, which may cause you to have irregular periods. So maybe you're not having a period every month, maybe you have a period every 3 months, etc. Or some women may not have a period for 6 months to a year. This is kind of what we see with PCOS. So as I kind of had already gone into, irregular or missed periods is what we see. Excess hair growth. So hair growth on your face, your chest, your stomach. Those are all signs of hirsutism, which is what we call the physical signs of having too much testosterone in your system. You can also have acne or oily skin, thinning of hair, or hair loss. and weight gain or difficulty losing weight, and then of course fertility challenges. This is a whole nother talk in itself, but I would like to make a shout out to the fact that PCOS is very real, despite what social media unfortunately promotes nowadays.
Can you explain that? There are people out there telling people that PCOS is not real?
Yes. So unfortunately, I think that there is like this misconception that people aren't losing weight, you know, because they don't want to, or like because they're not trying hard enough. But there are so many, and you know, I'm just kind of like briefly touching the surface on PCOS. There are so many other medical conditions you can have that contribute to issues with weight loss. And some of that has to deal with like insulin resistance. Some of that has to, it just deals with hormones. So maybe things that a normal regulated hormone person does and they lose weight may not function for a patient with PCOS. But I have seen some stuff float around. And I don't know if you guys have. Maybe I'm just like on a very weird side of TikTok.
I mean, you never know. The things that come on, like everybody's algorithm is different, but this also doesn't sound weird. I feel like on there, they be just saying all kinds of stuff just to say stuff. So, but I was like shocked. And you told me that people were out here trying to disclaim this particular thing, just essentially fat shaming people.
Yeah, exactly. And that's why I just wanted to like touch base on that. I don't know what your guys' experience is, but this is very real. It's a very treatable condition as well. And so that's, you know, it's complex, but I guess my point is you shouldn't feel bad about, you know, weight loss management, because there is certainly there are medical conditions that can contribute to those difficulties. And here there's
sharing that.
Yeah, of course. And here there's just like, you know, this cute little icon that I found that has like all these cysts, which can be found in polycystic ovarian syndrome. So who is affected by PCOS? This affects 1 in 10 women of reproductive age. It often starts in your teens or early 20s, and it can vary, right? Not too, like, there is no patient that looks exactly like another patient. There's no woman that looks exactly like another woman. So it's just, you know, everything is case by case and personalized. But usually younger women are the ones that are affected by PCOS, and it can be misdiagnosed, maybe because they didn't know it wasn't normal for them to have irregular periods, or maybe they were told at a young age that, you know, oh, your periods will regulate eventually. She's still young. Long-term health risks associated with this is, as I had mentioned, insulin resistance is one of the highest with PCOS. It puts you at risk of type 2 diabetes. And that's just because your hormones are not balanced appropriately. Another risk is heart disease, high cholesterol, sleep apnea, mood disorders like anxiety and depression. And then at the bottom, I wrote out endometrial hyperplasia. That's from unopposed estrogen. So, you know, just as I had shown you guys that nice little diagram of the menstrual cycle, I think, you know, even as I've like written all of this out for you guys, I'm even kind of recognizing how important our menstrual cycle plays into several aspects of our lives, right? So if your hormones aren't doing what they're supposed to do with your reproductive organs, it can have a lot of impact on your overall health. And so endometrial hyperplasia is when, because in PCOS, they don't, you know, you don't ovulate. So you have all this like estrogen in your body that's just estrogenizing, which, you know, in some ways is sometimes like estrogen is a good thing, but if you don't have those signals for your uterus to shed that endometrial lining, it's just constantly growing, and that can cause abnormal cells to start showing up, which can cause what we call endometrial hyperplasia, which are precancerous cells that can later turn into endometrial cancer. So as someone who works in both benign and also, cancer health, I think this is something that most people don't get, is that these conditions should be treated, especially because it can impact you in maybe a greater way than you wouldn't even really know.
Right, like beyond fertility, like beyond the simplification of about having babies. It's about your health as a human.
Exactly. So how do we diagnose PCOS? We use what's called the Rotterdam criteria, which means that patients need 2 out of these 3 things in order for us to say, yeah, she has PCOS. So 1 is irregular or absent periods. So infrequent cycles, rule of thumb, less than 9 per year. Long gaps between periods, so your cycles are longer than 35 days, or you don't have a period at all. Secondly is signs of high testosterone, so lots of androgens in your system. Acne, facial hair, body hair, scalp hair thinning, and these are confirmed by blood tests and physical signs. So just like those things that I mentioned, and then we would test your hormonal levels. So we would see what your androgens are doing, so what your testosterone is doing, and we typically also do test other hormones just to see what kind of imbalance is in the body. 3 is polycystic ovaries on ultrasound. So I actually had a picture of that over here. So as you can see, there are multiple cysts here. I don't know. It's hard for me sometimes to explain. I don't know if this makes sense, but it's like if you were to cut the ovary in half, that's what we're looking at here. So this is, all ovary and all these little black circles, which one of my mentors used to call chocolate chips when we would look at these images. It's like a cookie. It's like a chocolate chip cookie.
So the idea is we shouldn't have chocolate chips in there.
Actually do. And I should have put a normal one in there. They're just not as much. So we call this a string of pearls because it kind of looks like a string of pearls. Mm-hmm. That is classic PCOS. Usually to have a couple what actually looks like a chocolate chip cookie, if you can imagine, they're more separated. That's
got it.
This is
fascinating. It's fascinating.
Mm-hmm. Alrighty then.
I know some people here watch Grey's, so I'm sure they're fascinated as well.
Okay, so the next condition I'll go into is, what is endometriosis? So endometriosis is, as I've mentioned a lot during this chat, it's when those cells that are supposed to be inside of your uterus escape the uterus and they implant in other areas. So this can be your tubes, your ovaries, your pelvic or abdominal walls, which is that peritoneal cavity, which, if you can imagine, it's almost like a sack of, that's what we describe it as. It's like a sack of organs. And then your bladder and even your intestines, which is mind-blowing. This is kind of like a crazy story, but I've seen endometriosis that is so severe that it's been in the umbilicus and we can see it.
No way.
Yeah. Which is horrible. This is a terrible condition, and there's a lot of women that suffer from it, who go undiagnosed, and I'll dig into that again a little bit in a little bit, but it can be very severe, but it also could just be not as severe, but it still very much contributes to real pain, real painful menses. Those prostaglandins I've been talking about, which I'm like annoying myself saying prostaglandins during this chat. Those, they like induce inflammation. So that's what triggers these things to bleed. So if you can imagine, your pelvis is covered in these implants that are supposed to be there. And then every month they're having like their own like mini periods, you know, for lack of better words. That's going to cause you to feel bloated. You're going to have pain wherever they're located. So, you know, you're going to have bloating, you're going to have cramping. Sometimes it can lead to painful sex. In very severe cases, when there are implants invading the bladder and the intestine, it can cause pain with urination or even pain with bowel movements. Untreated, well, not necessarily untreated, but if this happens for a long time, it can cause cysts. So chocolate cysts, which I'm happy to share pictures with whoever's interested. But they're like these cysts that form because those cells are bleeding inside of your body, and they like form their own little cyst. There's also adhesions that form. So that's a fancy term for scar tissue. So you have scars that are forming in your abdomen, which can cause all of these organs. As you can tell, they're all very close together to kind of start sticking to each other. So all of that can also contribute to pain and very much contribute to pregnancy issues in the future.
Okay.
So who's at risk for endometriosis? People assigned female at birth who are at reproductive age. So usually anyone that's, you know, having menstrual periods can be at risk of endometriosis. A family history. Typically, most patients will say, my mom had this, my aunt had this, you know. Early onset menstruation, so before age 11. And you just have to think, right? Like, so the longer you are having menstrual periods, the more there's a risk of those cells escaping the cavity. Short menstrual cycles, heavy or prolonged periods, and people who have never been pregnant before, never given birth, because you're having those constant menstrual cycles where it gives those cells an opportunity to escape the uterine cavity. And again, having other chronic pelvic pain conditions like IBS could be a sign that maybe you have endometriosis. I tagged along adenomyosis here because it's essentially very much a similar condition. The only difference is that adeno implants in the wall of the uterus. So this, as you can imagine, causes inflammation, can cause the uterus to become bulky, and certainly cause tons of pelvic pain. The symptoms are very similar to endometriosis: heavier prolonged periods, pelvic pressure, bloating, frequent urination or difficulty emptying your bladder, pain during sex, and of course fertility challenges or miscarriage. Ignore that bottom note. That's about fibroids. Alrighty. So one more thing that about adeno is, and I think I dig into this a little bit more in my other slides, is adenomyosis. Unlike endometriosis, the difference is that because it's in that muscular wall, we don't diagnose it the same way. But I'll touch on that in a bit. So next I have another very real picture of real anatomy that deals with endometriosis coming up. So how do we diagnose endometriosis? And this is what I wanted to talk about with adeno versus endo. So here you guys can see, I think I was able to zoom in on this earlier today. No? Okay. So here is our uterus. Here's the fallopian tubes and the round ligament. And the endometriosis is these little spots right there on the wall. So you can see that, like, sometimes they look a little bloody, sometimes they're like dark red, but those are those endometrial cell plants. Here's ovary, here we have intestine right there. So this is treated typically through a clinical diagnosis. And what that means is that we diagnose it based off of your symptoms and your history of your menstrual cycles. So tools for diagnosis are pelvic exam, ultrasound or MRI, and then laparoscopy, which is surgery. So I'd like to recap that a bit. It is often Oh, I just saw this comment. To cause so much pain, they're smaller than I thought. Yeah, absolutely. But if you can imagine, every month, like they're causing all this inflammation, that sends so in this wall right here, that lining of your abdominal and pelvic wall is full of nerves. And the reason why is because it's like a sack of organs, right? So in this, if there's anything wrong, if you have like if something were to like perforate your bowel, or you were to have too much bleeding inside of there, all of those nerves are going to tell your body that there's something wrong. So as you can imagine, those little cells inflaming all of those nerves are going to cause tons of pain, tons of bloating. It is a clinical diagnosis because we don't want to do surgery on young patients. So usually we go by history. So, a patient who's had a history of painful periods, bloating, severe pain that's, causing them to miss work, missing social events, all of those things. Our exam and imaging studies can help, but they're not definitive diagnosis. Definitive diagnosis is dropping a camera in, seeing those spots, and then we biopsy them. But, as I mentioned before, this is avoided because we don't want to do surgery on a patient that's young. So we wouldn't do that unless it's absolutely necessary. Adenomyosis, the diagnosis for this is tricky because, these little cells implant inside of the uterus, like wall, so we can't see those surgically. So typically they're confirmed after someone has a hysterectomy, but you don't need to have a hysterectomy for us to diagnose adenomyosis. It can be seen on ultrasound. MRI is more specific for it. So there are ways for us to diagnose it off of your symptoms, your history, and then any imaging that'll confirm that. Here is another laparoscopic view of endometriosis. So here we have, all these little spots that are like causing inflammation. Here underneath this, bowel is right here, but this guy right there is what we call a chocolate cyst, like I had mentioned previously. So endometriosis ongoing causes these cysts, and they look like this. And for obvious reasons, we call them chocolate cysts because if they rupture, they have this dark brown, dark red, like fluid that's in there. And what that is, it's old blood, because these cells are bleeding the same way that they do every time you get your menstrual cycle. But that's happening inside of your body instead of outside. So yeah, that's false. So for one, sexually transmitted infections. You can have a sexually transmitted infection and never have symptoms. You can also have fibroids and not have symptoms. And then, as these conditions progress over time, they can worsen, and then you begin to have symptoms or start having long-term effects, like even with pregnancy. This is just a quick, like, same slide I used earlier, just, going over these conditions. And that'll bring me to the next topic, which is fibroids. So these are certainly a condition that can, not have any symptoms, and you may have it, but you may also, have symptoms. So there are these non-cancerous masses that we call leiomyomas or myomas that are made up of muscle and fibrous tissue that grow in or around the uterus. So in this little diagram, you can see they can sometimes be like, that's not like exactly inside, it's still like technically in the muscle wall, but they're like, they can hang into the endometrial cavity. They can be right in the muscle wall here. This submucosal, subserosal, intramural, that's just our terminology for like how invasive they are in that muscle wall. And then they can also be subserosal, which means that they're hanging out really close to that outside of the uterus, and they can be really large.
Oh wait, there was an anecdote that you had told me earlier about how many, it wasn't fibroids, it was endometriosis that you removed from someone.
No, it was fibroids.
It was fibroids?
So yeah, so you can have tons of fibroids. Or you can have one or two fibroids. You could have just one fibroid. But I was telling Glenelli's about, and I'll show you guys a picture very, very soon, of a real like uterus that, and you can see all the fibroids on it. We had a patient that we took back to the OR to remove her fibroids to help with her fertility, because as you can see, if that is in your muscle wall, that can, create an environment where maybe a pregnancy wouldn't want to implant or wouldn't want to grow. And she was very interested in having a baby. And so we took her back to the OR. We took out all of her fibroids, and I don't remember the exact number other than remembering it was over 90 fibroids.
90, like 90, you said 90.
It wasn't even 90. It was like, I don't know, like 93, 96 is kind of what's coming to my memory. I don't recall how many, but I know it was over 90. And that is like a variety. They were like, some of them were like, maybe like a golf ball size. Some of them were much smaller, but we went in there, we removed all of them. And, there's more to that in terms of like what that means for future pregnancies, because certainly after you've had a big operation like that, we would recommend C-section and very close follow-up during your pregnancy. But this is just part of what we do sometimes to help women.
Wow.
Yeah.
I'm glad that she saw you guys. I don't know. That's a lot. So also, how long was that surgery?
How long?
Yeah.
I actually don't remember. They usually, I don't know, that one was probably like maybe like 5 or 6 hours long. I don't know. Hard to say.
I lost track after all that. Wow.
But yeah, so fibroids, 1 or 90 or however many, they can cause really heavy, really long periods. They can cause bloating, pressure. These can cause you to have pressure on your bladder, which causes like frequent urination, maybe difficulty emptying your bladder. They can cause pain during sex, and then they can cause fertility challenges. But again, just to recap, some fibroids may not have any symptoms at all, which honestly usually is okay. I'm not saying that just because you don't have symptoms, you have to get treatment. You don't. But it's just kind of a more of an empowerment for you guys to take away that it's important to have your health checked and to know what's going on in your body, because if left untreated, this can potentially cause issues down the line. So here we have another trigger warning.
We're seeing real pictures now.
And so here is a uterus that has multiple fibroids. As you guys can see, there's some that are like medium size, some smaller ones, and that's kind of, you can see here how it distorts normal anatomy. And then this is just so yes, it's important. So who's at risk? So most commonly, it's going to be women in the ages between 30 to 50 when they get diagnosed. You don't have to be that age. You can be younger, but this is usually when we diagnose them. The highest risk is amongst African American women. There's, typically they'll start having symptoms earlier on, and then it might be also more severe. Risk factors include family history, hormones, obesity, and low vitamin D. And then this just kind of goes over what I've talked about. Over time, they can affect you in other ways. Another condition that we'll be chatting about today is pelvic inflammatory disease. So this is an infection of your female reproductive organs that includes the uterus, the fallopian tubes, and the ovaries. It's caused by bacteria spreading from the vagina or the cervix. It is most commonly caused by STIs or sexually transmitted infections like chlamydia and gonorrhea. But just a side note, doesn't have to be that. It doesn't have to be a sexually transmitted infection. It could be any bacteria that overgrows in the vagina and makes its way up into the uterus. So all of that to say, I have had patients before who have asked me, this is a pretty common question, which is why I was going to throw in this personal tidbit. But I often do get asked by patients with this diagnosis if there was any concern for their partner cheating on them because they think that this is caused by a sexually transmitted infection. But I'm here to say that that doesn't mean that. This can be caused by any bacteria that goes into the uterus. So this is why after having a baby, after having a miscarriage, an abortion, or any gynecological procedure where we use instruments to go into the uterus, you can push any bacteria in there. That would lead to an infection, inflammation, scarring, and can certainly cause issues with pregnancies, like can cause infertility because those tubes are blocked. So they're unable to grab that egg, or even ectopic pregnancies where that blockage of the tube now has caused an implantation of a fertilized egg inside of the tube. So how do we diagnose pelvic inflammatory disease? There's not one test that gives us a diagnosis. It's based on a combination of clues. So symptoms and medical history, pelvic or lower abdominal pain, unusual vaginal discharge, painful sex or painful urination. You can also have some irregular bleeding, recent sexually transmitted infections, new partners, or even a history of PID. Usually for me, it's a combination of, like I mentioned, your labs could be completely normal, but you still have very real pain, very real symptoms. Your vaginal discharge is abnormal. And when I do a pelvic exam and, just being raw and real with you guys here, we put 2 fingers in the vagina, we push up on that cervix. If you have unusual pain there, which you shouldn't have pain during a pelvic exam, I'm also here to say, it can be uncomfortable, should not be painful. If it's painful, if me pushing on your cervix is painful, or me, manipulating your uterus is painful, for me is a sign that there's an underlying condition going on. Usually, we're talking about PID, so that would be a positive sign for that there's like an infection or inflammation. So the labs that we usually do like vaginal cervical swabs that look for STIs. We also look for other bacteria. It can show up on your urinalysis or even your blood work. And then we normally would do a pregnancy test to rule out an ectopic pregnancy, which means like it's a pregnancy that isn't no longer inside of the uterus. Imaging is useful sometimes, but only if you've now grown abscesses or have like dilated fallopian tubes. So you can treat PID even without a positive test, which is usually, like I mentioned, would be based off of your exam and your history, because we also tend to, I think we kind of do push for over treating a little bit, because this is a very serious condition that can lead with future complications. So that leads to our next statement. Oh no, just kidding. It's a trigger warning. So this is something that we call a frozen pelvis. So a little bit different than what we had seen earlier. You can see here is the uterus. This right here is fallopian tube. And this is all part of the fallopian tube. So those are those finger-like projections I was telling you guys about that overlay, like kind of hang out on top of the ovaries. Here are the ovaries. Everything is like all like stuck together. And that is what pelvic inflammatory disease can cause. But also endometriosis can cause this as well, because that inflammation causes scar tissue, which is like sticky, to stick to all of your organs. So this is why we treat, and why I would rather like lean towards the safe side and give a patient antibiotic treatment, you know, for a suspected infection than not, and potentially complicate her life in the future. So now that leads into the next one. If tests are normal, there is nothing wrong.
False.
Love it. Yeah, that is false. And it doesn't just apply to pelvic inflammatory disease. You can still have normal ultrasounds, MRIs, and other imaging with the treatable condition. And there are conditions that require a biopsy for diagnosis, such as like endometriosis. So why do these things get missed? So
this is my favorite part, because I feel like it's so much like when it comes to women's health and women advocating for their health, they always feel like have to like, or they, depending on the provider, obviously, like a good provider will listen to you. But I think that there is a lot of skepticism when it comes to women and their pain and why these things get misdiagnosed. So
of course. Gotta watch more Grays. Yes and no. So why do these things get missed? So specifically endometriosis. Why do we underdiagnose endometriosis? And it's because it doesn't show up on imaging. And I'm here to say it doesn't show up on blood work. It doesn't show up on you can't diagnose endometriosis on blood work, on imaging. So you can have every test available and still not be diagnosed. Like nothing's going to show up positive. The way we diagnose it is by actually looking at that pelvis. And, you know, obviously we're not going to drop a scope in every patient. I think that this is kind of where the balance of medicine plays in, where it's an art. So it's a balance of me intaking the information from my patient and listening to her history, to her story, her complaints. And then from there, treating with an option that could help her. And I know that maybe not everybody likes that answer. And I'll go into like some of the things that we recommend. But certainly, you know, we kind of treat, and if the patient improves with the treatment that we're recommending, then it kind of tells us, okay, this is working, versus jumping into surgery right away. Adenomyosis, why does that get missed? And again, it's similar to this again. It can be subtle, or it can miss on ultrasound. Even MRIs sometimes may not show it. Surgery is less, we don't do surgery to diagnose adenomyosis. So it's very much still, again, listening to our patients and doing treatment plans that we're kind of like we're putting them on a treatment plan to see if they improve, and if they improve, that kind of confirms what we suspect. Chronic PID, why does that get missed? And as we mentioned earlier, you may not have symptoms that you have an infection, so it could certainly still be affecting you. PCOS, you don't need cysts to have it. It's based on symptoms, some hormone levels, and pattern recognition. So another statement. It's a bad thing if I don't have a period.
I'm in the camp of damned if you do, damned if you don't. I kind of feel like about it. Anybody else have thoughts? Yeah, I think true.
Alrighty. So this is true. So good job, you guys. But it's also false. And I'll dig into that.
Trick question.
So it's which I think you guys were on this. So yes, not having a period is a bad thing. And we've already talked about that, right? Naturally, you should be having a period every month. If you're not, it could certainly be a sign that you have thyroid problems, PCOS, maybe you don't have enough body weight, and sometimes that just means you don't have enough fat cells that kind of help with those hormonal levels that we see in our normal menstrual cycles. Maybe you're overexercising. Maybe you're having early menopause or ovarian insufficiency, which means your ovaries aren't working properly. So you guys are right. Not having a period should definitely kind of signal you to seek evaluation from a healthcare provider. However, this is false in the setting that your healthcare provider, your lovely Lorena Madera, GYNPA, suppress your period. So this happens with birth control. And I think that this is something that I have actually seen predominantly in the Hispanic community, that a lot of Latinas think that it's not okay for them to not have periods, even if we're suppressing it with birth control. So it is safe and it's beneficial to not bleed when you're having birth control pills continuously. So you guys, I'm sure if you've had birth control pills, there's usually 3 weeks where you take your hormone pills. And then there's that 4th week where you're off of hormones. It's like a placebo pill. So it's okay for you to skip that week and just continue birth control. IUDs, such as like the Mirena, Kylena, if you guys have seen them, they're the little T-shaped guys that go inside of the uterus. And they provide hormones. And then there's also hormonal injections or implants like Depo-Provera, or if you guys have ever heard of Nexplanon, which is a bar that goes inside of your arm. But these are hormones that actually suppress ovulation, which is why they are successful in contraception, because they're allowing for you to not get pregnant. So that endometrial lining is actually too thin to support a pregnancy. So there's no buildup, so there's no harm. In comparison to if you were naturally not having periods and not shedding that lining every month. So the bottom line is, if your period stops naturally, you should check in with a provider. And if it's stopped because of hormones, that's totally safe and actually helpful for any condition, that it's applicable to.
Great to know. That is, in my mind, it's like we're supposed to, which we are, but not if my doctor helps me not have it.
The next statement is birth control cures chronic pelvic pain. What do you guys think? It depends. You guys are right. I've made you guys so skeptical. Yes. So actually, Ellie is like hit it right on the head. False. It doesn't cure it, but it can treat the symptoms. So what can birth control do? So it can reduce bleeding and cramping. It again suppresses ovulation, like what I mentioned earlier. So this is why it is a treatment for endometriosis, because those cells that are outside of the uterus are also thin and no longer producing that monthly menstrual inflammatory process. It can also help with cysts, which I didn't dive into too much on this talk. It can also manage hormonal symptoms of PCOS and then help fibroid or adenomyosis growth. It like slows it down. What it does not. So birth control does not remove scar tissue or adhesions. It doesn't treat infections, and it doesn't fix underlying inflammation or mechanical issues. So things that are already present. And it doesn't work for everyone, right? Side effects matter. And that's a whole nother talk in itself. But, I think that is something important. If you've been on birth control and it doesn't help you, to talk about all of the options with your healthcare provider, and find the thing that works for you, whether that's the pill or maybe an implant, if that's something that you're interested in. So bottom line is birth control can be a helpful tool, but it is not the whole toolbox, which leads me into the next slide of medical treatments and approaches to all of these conditions that we've talked about today. So PCOS, normally first line therapy for us is combined oral contraceptives, so a pill, and anti-androgen medication, which brings down your hormone levels, that are like testosterone levels, spironolactone. We also do use insulin sensitizers, which means that it helps you process that insulin that PCOS might be resistant to. So we usually use medications like metformin to improve your metabolism, improve the way that your body is responding to insulin. And I've actually, we do treat patients with metformin when they're trying to get pregnant with PCOS. It actually helps regulate their cycles. Weight management.
So you can get pregnant even having PCOS.
Yeah, which that is also, I know, I kind of, I thought about adding that one into this presentation, but yeah, you can get pregnant with PCOS, but it's like, you can get pregnant with PCOS, but it's something that does complicate pregnancy. But there are ways that we can help you regulate your hormones. Obviously, birth control is not an option for a woman that wants to get pregnant, but things like metformin, even lifestyle changes, like exercise, can all regulate your hormones and help with the ovulation process. Pain management, we usually use non-steroidal anti-inflammatory drugs like ibuprofen for any symptoms that patients might experience. Endometriosis and adeno, we do, again, hormonal therapies, so pills, progesterones, GnRH agonists, which is a fancy term. All of this is just medication, and yes, external hormones. I know this is a little, like, a shout out right here. Hormones aren't necessarily always bad. I think that there is a very big misconception about hormonal therapy, but these hormones are not, they're not really changing the way that your hormones are. They just suppress. So it's like, we kind of put you in a state of like not ovulating, which sounds scary, but during that time, that's what helps with like not getting pregnant. Also helps with that inflammatory process that you're experiencing every month. So, overall theme of these treatments you'll see is very like anti-inflammation. So pain relief, again, ibuprofen for cramping and inflammation. Hormonal IUDs are also a really good treatment for endometriosis, And this is a more localized hormonal therapy. So if you don't want systemic hormones that affect, that are the ones that usually produce the most side effects, like weight gain or fatigue, bloating, things like that, hormonal IUDs are an excellent option because it's just localized to the uterus. Then minimally invasive surgery. So sometimes we will do surgery if, the endometriosis is so extensive, like I had said, someone with like endometriosis in their belly button. We have done surgery on patients like that to remove all of that abnormal tissue and to give them a chance to, have better pain management. Another thing is, so for uterine fibroids, hormonal control, again, it can help slow down the growth of fibroids. We sometimes give tranexamic acid, which is a medication that helps with bleeding. And then there are also things like uterine artery embolization, which is when we block off the artery or the vascularity that's going into the uterus, so the blood supply, so that you don't have as heavy bleeding. Pelvic inflammatory disease, we are going to treat with antibiotics. And then in severe cases, I have had patients that get hospitalized to get like IV antibiotics if they have abscesses that have now grown, internally. Big thing from pelvic inflammatory disease is if you are diagnosed with a sexually transmitted infection, then get your partner treated as well, because you can certainly continue to have a reinfection. And then follow-up is important in pelvic inflammatory disease, making sure that, we ensure that you have resolution of this infection, of this issue, and then preventing any long-term complications. So, complementary and natural approaches to these conditions. I think a lot of times I have had patients who maybe are skeptical of the medical approach, and I'm here to say that medicine is a balance. It's like an art. So you take what works for you, and it should be a conversation with your provider. If you want to lean more holistic, just talk to your provider about it. There are providers that are open to these other alternative methods, but I do think that it has to be like a wholesome combination of the two. So for example, focusing on this like anti-inflammation. So your diet with PCOS would be like low sugars, anti-inflammatory. So things like avoiding caffeine, avoiding red meat. Supplements, they're not like fully studied, but there is some data to say that inositol, omega-3s, and spearmint tea can help drop those testosterone levels. Exercise, any regular movement is going to help that insulin sensitivity as well. With endometriosis and adenomyosis, an anti-inflammatory diet, so reduce your red meat intake, processed foods, caffeine. Acupuncture has also been found to help some pain relief and hormone regulation. I've had patients who use castor oil packs that might help support pelvic circulation, and then vitamin D, which reduces some of those like pro-inflammatory cytokines. Uterine fibroids, so I was looking up some of this stuff, and green tea extract can help. I believe it's like it reduces, it can help like reduce the growth. And then there's also detox support. So your liver processes estrogen, and it's things like broccoli or spinach, all of those things can help that metabolism of the estrogen. So the lower your estrogen levels are, the less like promotion there is for fibroid growth. Obviously, stress reduction, such as meditation, breath work, and then yoga is really big because it really helps with that pelvic muscle. Your pelvic muscles, it helps, stretch them. It helps with pelvic support, so can certainly help as well. And then in pelvic inflammatory disease, probiotics, vitamin D, zinc, pelvic floor therapy, I think is something that could be used in any of these conditions, but it addresses that muscle tension. And this specifically mentions post-infection, but I think that there's not enough people who know about like pelvic floor physical therapy. So that's always an option for patients with chronic pelvic pain. And then anti-inflammatory lifestyle is, in all of these, specifically in PID, would be due to reduce any scar tissue. The next statement is pregnancy will cure your chronic pelvic pain.
I don't feel like pregnancy cures anything. As a former pregnant person. So I'm gonna go with false.
Alrighty. So yes, it is very false. So while I see that Ellie dang it.
Dang it.
So I mean, this is something that people say all the time. Like, oh, just get pregnant, it'll cure your endometriosis. Oh, get pregnant, it'll help your pain. Which it's kind of like I'll go into that more. It might provide a temporary relief of your systems, but it's not a cure. And to kind of tag along, you said that Ellie said they always say it resets your system. And I think that comes from the fact that, you have a change in your hormone levels, but those hormones, ironically, are working in a similar fashion to birth control. And I know that sounds like super contradicting right now, but if you think about it, when you're pregnant, you do not ovulate, right? Because your body already knows that you're pregnant. So you're not going through like a normal menstrual cycle. It's suppressing ovulation. So it's functioning in a similar manner than like birth control, where you're no longer ovulating. So it can provide a temporary relief of symptoms, but it's not a treatment or a cure.
Fascinating. I mean, yeah, the not having a menstrual cycle was a perk, but the rest of it was just so much in the opposite direction.
Yeah. So again, kind of what I said, it increased progesterone and relaxin can relax the smooth muscle, and it reduces uterine contractions, which can temporarily ease pain in conditions like endo, adeno, where there's this like recurrence monthly of inflammation. For, like I said, you have menstrual cycle pauses. So no menstruation means no cyclical bleeding, which triggers pain from endo, pain from adeno, even pain from your fibroids. And immune modulation, which, your pregnancy suppresses parts of the immune system to protect the fetus. So your immune system dampening is going to reduce inflammation and pain in conditions such as the ones that we just mentioned. So again, this is not a cure. Postpartum pain will often return, and sometimes it can be worse because now you've had pelvic floor trauma. Maybe you have scarring from a C-section or even a vaginal delivery. And hormonal shifts during breastfeeding can sometimes also add. When you breastfeed, you release oxytocin, which is a hormone that makes your uterus contract. So that can also affect your pain.
Which is the craziest sensation, by the way. Like, it's so weird, but it does actually happen. I remember hearing it and I was like, what does that mean? And I was like, yes, I actually do feel that happening.
Yeah.
Wild. It's wild what the body does, but it's fascinating.
And then pregnancy can worsen your symptoms at times. Maybe if you have increased pelvic pressure from now your uterus is bigger, and if you had big fibroids, as you can imagine, like we had seen, everything is, it's a small space. So uterus grows. If you have a fibroid, starts to cause maybe issues with bowels, maybe issues with urination. Maybe you start to have back and joint pain. So the relaxin, what we're talking about is these hormones that they relax all the ligaments and the muscles, because if your body's preparing, to make a baby. And during that, sometimes it can actually cause you to have more pain. So if you hear about round ligament pain in patients, things like that. And then hormonal fluctuations that, might actually trigger issues with patients with PCOS and endo. Another statement. So it's my fault I lost my pregnancy.
I'm gonna go with 100% false. Like big Kanye letters, false. A horrible lie. Agreed. Horrible lie.
So yes,
Very false.
Very false. So it is not your fault. And we'll touch a little bit on sex, exercise, stress, contraception, and abortions. So the majority of miscarriages, especially in the first trimester, the most common cause of a miscarriage is chromosomal abnormalities. So from the time that embryo was formed, it was already abnormal. There were already issues there that triggered your body to know it was an abnormal pregnancy and it wouldn't be sustainable. So that is your body's natural mechanism of getting rid of that abnormal pregnancy. About 1 in 6 couples worldwide experience infertility, and in up to 50% of infertile couples, there is a male factor involved. So this is not a female issue. This is 50-50 here.
Glad we have it on written on paper here for us to see. It makes it, I mean, we know it, but, or maybe people don't know it, but I like seeing that in black and white, essentially. They have fault too.
Yes. So certainly it can either be alone or in combination with the female factors. And it is not your fault. It's not related to your stress levels. It's not related to you heavy lifting. It's not related to sex. That is a very common thing I hear patients sometimes. I had sex and then I started bleeding. Am I at fault for this? Did I do something wrong? And no, sex shouldn't impact your pregnancy. And just a little shout out there to ACOG, which is the American College of Obstetrics and Gynecology. We actually do recommend 30 minutes of light exercise a day in pregnancy. Just goes to show that none of these other factors are the causes. So common infertility causes: ovulation disorders like PCOS, fallopian tube damage from endometriosis or an infection, uterine cervical tissues, uterine or cervical issues. So fibroids creating an abnormal cavity, cervical issues being your cervix maybe dilates too early in pregnancy, it can be from procedures you've had on your cervix, Age-related egg decline. So as we age, our ovarian reserve continues to lower. And then premature ovarian insufficiency, which would be your ovaries are just, they don't function normally. Again, 50-50 here. These are male infertility causes. So low sperm count or poor sperm mobility. Varicocele, which is an enlarged vein in the scrotum that might actually block the passageway of the sperm. Hormonal imbalances, any genetic issues, and any past infections, trauma, or even exposure to toxins such as heat, radiation, or alcohol. All right. Our next statement, I cannot get pregnant because I used birth control at some point in my life.
I actually believe this for a time. I thought that this was true.
All right, so this is false. Birth control temporarily suppresses ovulation, but it does not cause permanent suppression. So just to dig into that some here. So just a brief overview of how birth control works. So hormonal birth control, like the pill, the patch, the ring, IUD, or the shot, it prevents ovulation or alters the uterine environment. So altering the uterine environment specifically in the sense of the endometrial lining, right? That's no longer nice and thick and juicy for implantation, but this is something that happens on a monthly basis. So us, suppressing that doesn't mean that you won't ever be able to ovulate again. Once you discontinue the birth control, the shot does suppress for about, you can have suppression for 6 months after you get it. But any of these other things, the minute you discontinue your birth control pill, the minute you discontinue a patch, a ring, or an IUD, usually, fertility resumes pretty soon, if not immediately. Your body usually resumes its natural cycle within weeks or months. But I'm here to tell you that I've had patients who get pregnant the weekend they took their IUD out. So also something to be mindful of. Sorry guys. And then again, so temporary delay in ovulation. Birth control can mask those issues that were already present because these are ways that we manage these underlying conditions. And then some birth controls can protect from future fertility problems. So any, ovarian cysts, fibroids, endometriosis, sometimes birth control can help with that. And then just a little shout out to untreated sexually transmitted infections. Birth control doesn't protect you from getting gonorrhea or chlamydia. So if you're gonna be, living your best life, just a little shout out to condom use for the moment while you're having multiple partners. And then here is the truth about abortion, which I just wanted to briefly mention. Safe legal abortions do not cause infertility. So vast majority of people who have abortions can go on and have healthy pregnancies later. There's no evidence that taking a pill for an abortion or even having a surgical procedure where we remove the pregnancy from your uterus causes infertility. Fertility resumes shortly after you have an abortion procedure. And abortions do not damage the uterus and do not damage your ovaries when they're performed safely. What can affect your fertility is untreated infections like we've talked about today, unsafe abortions performed in non-clinical settings or without proper care, and multiple uterine procedures. This is rare, but if you have had multiple what we call dilation and curettages, or even so that is if you have multiple of those procedures, if you scrape the lining too much, it can cause scarring but this is very rare, and we don't see it after just like 1 or 2 procedures. This would have to be like multiple. Alrighty, our next statement is, I should try for a year before seeking fertility treatment or evaluation even.
I mean, a year just seems like a long time. So I'm gonna say false. I think false. Got a false, another false. I think the consensus is this is false.
So again, it depends.
Oh wow.
We'll talk about this some more. So if you're under 35, we do usually recommend that you wait for 12 months before seeking ovulation. Ages between 35 and 39, we say wait 6 months because there's a lot of factors that go into fertility, right? So not to say that you're going to get pregnant the first time you try, but we do recommend that you try it. It's more so coming from like, we don't want you to be discouraged and think that you have a problem if you're unable to get pregnant after a month or 2 of trying. If you are over 40, this you should seek evaluation right away. And that's really just because that ovarian reserve is dropping, and we want to make sure that you get evaluated. The sooner the better. However, this is where it kind of, disclaimer, regardless of age, if you are not having normal periods, right? Or if you've been diagnosed with PCOS, endofibroids, if you have a history of sexually transmitted infections, a history of abnormal pregnancies, which would include miscarriages, ectopic pregnancies, anything like that, then I would seek medical care before trying for 12 months. When we say try for 12 months, those are women that have, periods every month, so they know they're ovulating. That last portion says anovulation while trying, and there are women who will like test their like luteinizing hormone. Those are the ovulatory prediction kits, if you guys have ever heard of them. Those strips that like, you like pee on when you're like trying to track your cycle. So if you're checking that during your ovulatory days, which would be like day 11 through, again 15, and you're not seeing that LH spike, then that can mean you're not ovulating. And so I would seek treatment at that point, and evaluation. Really, it's evaluation. Treatment isn't the right word.
That is crazy. I would have not thought that like 1 year. And I guess I wish that was more known, because it would help people like not feel so terrible when they are trying. Like it makes them feel like a failure in instances where like that's what they want. Man, love these myth busting. It puts everything so much more into perspective.
Yeah. I know, I think that's why it's just important to have these conversations, so we can, talk about, there's so much like misinformation out there. So, and I'll get into any questions you guys have in just a moment. I promise I'm almost done. Thank you for staying with me. This is the next one. I cannot get pregnant during my period. What do we think, you guys? You can certainly still get pregnant. Another fact here is, if you have short cycles, you can actually ovulate sooner. So if that sperm is like chilling in there, making a home in your uterus, and that little follicle gets sucked up by those finger-like projections, then there you go.
Crazy.
Were you gonna say something, Ellie?
Oh, I'm so sorry. You kicked me out, so I'm back.
Oh, sorry, I just saw that you weren't muted, so I was like, oh, Ellie's gonna say.
Oh, sorry.
No, it's okay. So yeah, so that kind of ties up the last like myth that we busted today. I have a couple of slides that just are more like questions leading into our Q&A. So when should you see a gynecologist? I don't know how applicable this is for our audience since I don't know you guys personally, but if you guys have teenage girls, then I would recommend, it's not like a straight cutoff, but I do think it's important that once they start having their menstrual cycles, they not when they're have their menstrual cycles, but if there's anything unusual that you guys see, if they're missing periods, if they're really painful, those would all be signs to take them to a gynecologist. I was reading like actual recommendations because I personally don't think that there's a cutoff. I think it's like if you're questioning that anything is abnormal, if you have a question that something's wrong with, your menses, with your pain, you should see a healthcare provider to see if there are any answers that you can get for your questions. However, on that note, from age 13 to 15, they should be having their menstrual cycles. So it probably is beneficial for them to have their first visit during that time. And really, it can just be general health, establishing care with a gynecologist, talking about things like we did today, right? Them learning about their anatomy and what that means and what's normal, what's not normal. It can also be a little introduction if they are going to be sexually active to maybe talk about birth control options for them, and practicing safe sex. Age 18 or when sexually active, so leading into that, if they haven't visited by age 18, it's a good idea to see a gynecologist as they're becoming sexually active. We'll talk about birth control then, STI prevention, menstrual health, and reproductive health. And then they'll start having their regular exams. We typically don't do like pelvic exams unless there's like a reason to until after age 21, when we do start recommending when we do start recommending routine pap smears. How often you get a pap smear is also, that's more so just based off of your sexual history, and if you ever have an abnormal pap smear. Here is again what I mentioned earlier. They should see someone if they have severe menstrual issues, pelvic pain, or pain during intercourse, abnormal discharge or bleeding, and concerns about sexual health or development. Another slide here, just kind of tying in, green flags in a medical provider that you may see. So someone who does active listening, someone who's actively listening to your concerns. They want to know your story. They want to know all of your symptoms. And they're taking the time and creating a safe space for you to say all of those things to them. Someone who's compassionate and empathetic. So they will be empathizing with you on these sensitive, very intimate topics that we have to deal with, right? And they create that safe space for you. Clear communication. Someone who will sit down and explain to you and, in non-medical terms, what's going on, underlying processes, and they encourage you to ask questions and feel comfortable and empowered about knowing what's going on with your body. And someone who has a collaborative approach, which means that they listen to what you want for your treatment plan, and they make this a two-way conversation. I always tell my patients, ultimately, you're in charge of your health. So if you do not want something that I'm recommending, you can always say no, but this is an active conversation between us, and it's a balance of me finding the best treatment that's personalized to your needs. Other green flags in a medical provider are someone who, is gonna respect your boundaries and respect when you may be uncomfortable. someone who's gonna make you feel comfortable while they're doing a pelvic exam that can be very invasive. Someone who encourages preventative care. So someone who will take the time to talk to you about why your pap smear is important, why your breast exams are important, why it's important for you to have STI screening. Also, lastly, this is obviously, these are things that you don't really get to vet until you meet the provider, right? It's the interaction that you have with them. But I think outside of that, looking up their reviews and their reputation. So someone who has positive reviews and feedback from patients and maintains a good reputation in the community, and they have a history of, professional and respectful care. So with all that being said, I apologize this was so long, but I hope you guys were able to learn something new today.